again, thank you, Ellen, for giving us this opportunity to speak about healthy ideas. And like she said, this is a new program that we launched in May. And again, like Ellen said, my director, Ray Parks, bailed on me today. So he was going to do some opening remarks. So he did send them along, so I will read them from him to you. Just pretend I'm Ray for a few minutes. This would have been Michelle and my introduction to you guys. But he was going to give you a little bit of background information on Rappahannock-Rapidan Community Services. It is Virginia's only combined community services board and area agency on aging, serving the counties of Culpeper, Fauquier, Madison, Orange, and Rappahannock. And as a member of V4A, which was the Virginia Association of Area Agencies on Aging, we had an opportunity to participate in a training initiative, which Ellen was speaking of, led by the Virginia Center on Aging, part of Virginia Commonwealth University. Early in 2021, RRCS hosted a series of 3 training workshops led by VCU. The final presentation focused on best practices and evidence-based programs to address older adult mental health issues. Through internal discussions and in consultation with partners in Aging Together, we reached consensus to focus on the issues of depression and social isolation for older adults and their caregivers. These issues were especially prominent during the COVID pandemic environment. After evaluating several program models, we chose to implement Healthy Ideas with startup funding obtained through PATH Foundation Senior Services Collaborative. We, the staff, received our formal training in Healthy Ideas back in March 2022, and then we launched and went live with Healthy Ideas in May. The program has been incorporated into the RRCS Area Plan for Aging Services as an ongoing source of health education screening and individual counseling. So that is the intro for Healthy Ideas. And as we were researching different ways of marketing Healthy Ideas, of course we were delving into depression, seeing how best to promote it within the counties. So we started with this presentation, which is called Reflections of Depression. And before we get into the presentation, though, I just had a few questions for the attendees. How many here think they would be able to tell if they or someone they knew had depression? Just show of hands. Would you know? As opposed to just the blues or having a bad day. Who can tell me some signs or symptoms of depression in older folks? Show of hands. Any signs or symptoms?
Activities they once enjoyed, they no longer enjoy.
Perfect. Anything else?
Isolating from families.
Loss of appetite.
That's a big one. It's either loss of or overeating. Yes, ma'am.
Not wanting to bathe or dress or change.
Personal hygiene, absolutely. Another one that I found interesting, because typically you think sadness. In the older folks, sadness is not necessarily the primary symptom. It is lack of interest or an increase in their physical complaints or illnesses, specifically pain. And that is an issue that clouds the diagnosis of depression because they're seeking treatment for illnesses or increased pain. And unless you have a very astute diagnostician for a physician, a lot of times depression goes undiagnosed, which is sad. How many people here have ever used the word depression and said something like, I'm so depressed because they canceled my favorite TV show, or I'm so depressed because my hairstylist is moving out of town, or I'm so depressed because I have this big pimple on the end of my nose. I mean, we've all done it. We've tossed the word depression around, just like we use the word kill. Like, I'm going to kill you if you just don't be quiet. Or, I'm going to kill that kid if he doesn't straighten up. I mean, it's so easy to throw words like that around, but the aftermath of that is it gets trivialized and or stigmatized. And so it becomes very difficult for folks who are depressed to seek treatment because, it's only a pimple on your nose, and people just blowing off their reasons of seeking treatment. Or the flip side of that is they don't want to be associated with the word depression and the stigma that unfortunately is attached with it. In our screening process, I know, and we'll get into this a little bit toward the end of the presentation, but screening folks for depression, a lot of people immediately, not me, I don't have depression, I'm good, I'm fine. So it's hard to dig deeper and get folks to fess up that they very well might indeed have an issue with depression. So as far as the presentation, we will jump into that. How do you know if you are an older adult with depression? And several of you have already touched on these. The majority is you've just lost interest in activities that you used to enjoy on a regular basis. You feel helpless, you feel hopeless. It's just harder and harder to get through the day, almost like you're trying to walk through wet cement. You're just in that slow motion, robotic, get through the day kind of mode. There is absolutely no joy in your life anymore. But unfortunately, again, if this reflects you, you're not by yourself. There are just more than 2 million adults over 65 that suffer from some form of depression. And just to put that into perspective, that is about the population size of Chicago or Houston, that amount of people. So as we do this presentation throughout the community, we have found that one of the big barriers to having people seek treatment is just education, lack of knowledge, what depression is. They either think it is a normal process of aging, or their family members blow it off as, oh, just snap out of that. But it is a medical condition. It interferes with everything in your life, your normal functioning. It is not a crazy person mood thing, which a lot of older folks associate that with. It's a mood disorder. It is a persistent feeling of sadness, again, no joy, walking through wet cement. It can happen to anybody. It does not discriminate. Doesn't matter how old you are, doesn't matter what color you are, what your occupation is. It is extremely, extremely far-reaching. It affects every aspect of your life. We try to also educate folks on what possibly may cause depression. There is not any one concrete reason folks are depressed, but possible causes do include genetics. You just can't get around that, unfortunately. Substance abuse plays a big part. You do have some control of that, but unless you seek treatment for that, you can roll into depression. So there's two things going on at once, unfortunately. In my opinion, a lot is early childhood experiences like abuse and trauma that no one's ever got counseling for, or they've kept buried their whole life, and then it comes to fruition as they get older. And major life events, we all have those. marriage, divorce, loss of a job, loss of a spouse, loss of a loved one. There's just no getting around major life events. It is how we react to those and get past them that becomes the journey to stay clear of depression. There are 3 types of depression. Healthy Ideas specifically deals with the second and third, the moderate to minor depression. If we are screening folks and they fall into the major depression category, we then send them forward to certain therapies that would do them the most good. The persistent depressive disorder, dysthymia, it's again very nebulous about, depression can last anywhere from 2 weeks to 2 years. Moderate, they say at least 2 years to be diagnosed with moderate depression, and minor do not last that quite as long, less than 2 years. And again, signs of depression, and you guys touched on a lot of these as well, is just a persistent sad, anxious feeling, just empty all the time, absolutely no joy, just pretty much don't care anymore. Loss of interest in normal previous daily activities that used to be pleasurable, and now it's just, there's nothing in it for them anymore. Again, they become very negative, pessimistic, hopeless, sad. There can be massive feelings of guilt. People are just feeling worthless, they're helpless. They don't want to be a burden on their family or friends. They can have decreased energy where they just either sleep all day, they don't want to get out of bed, they don't want to do their hygiene routines like they normally did. And then there's the difficulty with concentrating and remembering and making decisions because, again, you just don't care. It's just not of interest to you anymore. Somebody said appetite. People can stop eating. People can overeat. So there's those unintended weight changes, difficulty sleeping, difficulty waking up, or oversleeping. Of course, this is pretty straightforward. There's thoughts of death or suicide. Just as a side note, those 65 years and older, which is 13% of the U.S. population, account for 20% of all suicide deaths. And if you make it to 85, with white males being most susceptible, you have a 6 times the overall suicide rate in the United States, which just makes me sad. That is significant. Other signs of depression, grumpiness, irritability, you get restless, and unfortunately a lot of people will blow that off as older folks get into that age group of just being a grumpy old man, a grumpy old woman, and think that that's a normal thing. Again, signs of depression can be an increase in your aches and pains specifically, or other symptoms that don't really have a clear physical cause and that they do not ease with any type of treatment. That is the one thing to be aware of, without a clear physical cause. And another statistic for folks over 65, their health costs increase when they have depression. And typically it's because of trying to get to the bottom of the depression when they present with other symptoms such as aches and pains, digestive, cardiac. So that is why, again, I say it's very important to have a good working relationship with your primary care. and hope for the best that he or she is a very good diagnostician and listens to what the complaints are. Some of the risk factors: being female, yay, yay females. Not surprisingly, having a chronic medical condition, cancer. Who wouldn't be depressed if you got somebody came out and told you you had cancer? Diabetes, maybe not so much, but there is very debilitating levels of diabetes, and heart disease. I mean, heart disease in and of itself can debilitate you to the point where your activity level's restricted, what you can and cannot do has been restricted. So that certainly could lead to signs and symptoms of depression. Have a disability, already are sleeping poorly, lonely or socially isolated, which during the pandemic has just triply escalated all of the depressive symptoms that we've been seeing. And then having a personal or family history of depression. And I guess that will kind of circles back around to genetics. More risk factors: lack of exercise or physical activity. And I'm like, oh, that is not a good thing. So everybody needs to get up and start moving and working out. But I was surprised at that one, lack of exercise or physical activity. But that can certainly go hand in hand with isolation and just not having any interest in doing anything at all. If you've got Alzheimer's and related dementias, misuse of alcohol or drugs, and stressful life events, again, divorce, death, losing a job, chronic illnesses. Certainly all of that could lead into depressive issues. One of the challenges for physicians is determining, beyond if your clinical complaints are really depression issues, is it grief or is it depression? I mean, everybody's going to experience some kind of loss in their life. I mean, there's just no getting around that. Whether it's independence, mobility, a loved one. But the grieving process is normal. It's a normal thing to be down and blue and to go through that grieving process so that you can get back to where you were. It is normal. Most individuals will cycle through the grieving process and come out on the right side. However, some people just get stuck and they cannot cycle back through and get back to their previous level. And distinguishing between grief symptoms and depression symptoms can get muddy. So that's why I say, please share as many symptoms as you can with your physician so that they can determine the base cause. When you're going through grief, you still have good days. I mean, you have your bad days, but you get to a point where you can think back on whatever that trauma or loss was and think about the happy parts or the good times. With depression, you just can't. You stay in that bottom pit of despair, and it is constant. And there isn't a timetable, and like I say, I've read anywhere from 2 weeks to 2 years. If you don't get through it, then you're labeled with depression. I think it's an individual timetable. It just depends on your support systems, what event happened that might have led you into the depressive state. But if it's gone on for quite a while, whether it's 2 months, 2 years, and it is just, there is no joy. Everything is just extinguished and there is nothing that brings you happiness, then it is more than likely depression. And this being a dementia conference, it is also very difficult in the initial stages sometimes to determine between, is it dementia, is it depression? But But just because we're aging, that is not a normal stepping stone to the loss of mental sharpness. Dementia and depression do share very similar symptoms, specifically with memory, speech and movement, and the low motivation. And it can be an early warning sign of possible dementia. And then, of course, when you get that diagnosis of early dementia, which is the very scary part, suicide attempts do seem to increase because you're still cognizant. You know what that diagnosis is going to mean in the long run. So those suicide attempts and rates absolutely go up. And the next slide just kind of differentiates a little bit between dementia symptoms versus depression symptoms. With depression, it's pretty rapid. Dementia seems to be on a more slower decline. And in dementia, you're confused, you're disoriented, you forget who people are, familiar locations, you can go out and get lost. With depression, you're still alert and oriented. You know the time, the date, location, it's just, you just don't care. Dementia, there's difficulty with short-term memory as opposed to depression. Seems to be localized around difficulty concentrating because you don't have anything you're interested in, so you're just not paying attention to concentrating on anything. Dementia affects the writing, speaking, and motor skills of an individual. In depression, they just slow down. And with dementia, you don't notice the memory problems because you have dementia, and you don't seem to care. Or you negate people's observations of the fact that you have memory issues going on. And in depression, most folks notice or do worry about their memory problems. You're still aware, you're still alert and oriented. And we've already touched on this a little bit, but why it is so overlooked in older adults, because it is very similar to grief. Symptoms are very similar to dementia. But a lot of folks, and they don't have to be older folks, just in general, they just assume that it's normal for people to be down or blue because it's a part of aging. It is not normal. You could be isolated with nobody around you to notice that you're getting these signs and symptoms. So there's nobody to point it out to you, and you don't self-report because you think it's a normal thing that you're going through. And the physical complaints. Personally, I'm a nurse, and if my GI system was upset or my back pain got worse, it would not occur to me, the first thing to think of was that was a cause of depression. But again, that is one of the number one complaints that folks with depression have, is increase in pain. And not to be stereotypical, but you might be reluctant to talk about your feelings or ask for help, you guys. But again, with depression, because there is stigma associated with it, that kind of crosses all boundaries. It is very difficult to walk in to a physician's office, counselor's office, anybody's realm, and fess up to, I think I have depression, I've got this, that, and the other, because it is such a stigmatized word. And that's why we are trying to do these presentations, educate folks, make them aware that it is not a bad thing, it is a medical condition, there is treatment, and make them more willing to chat with their physicians and or their other providers about it. And the help and treatment options. Talking to your doctor is number one. Making sure that they have a thorough history what your complaints are, how often you've been in to see them for the same complaints, what treatments have been tried with or without success, so that they can eliminate any physical cause that can lead them better than to a diagnosis of depression for the individual. A lot of first-line treatments, once you get to that diagnosis point, are medications. I have found that a lot of folks who are prescribed antidepressants want immediate results. 2 days in, they're like, oh, doesn't work, I'm still depressed, and then they toss them in the trash. These medications can take up 2 to 4 weeks to build up levels in your system. So I really encourage people to just power through, take them, follow up with their physician. In that time frame, if they're not seeing any improvement, certainly there are alternative medications, and that just might not be the right one for them. Psychotherapy, which we try to take the psychotherapy word out of there. It is just talk therapy. That seems to go over a little easier with people. It helps folks to rethink how they're behaving or changing habits that might be keeping them in that spot where they just can't get back up to the way they used to be. And then another treatment option, which brings us to Healthy Ideas, are evidence-based programs. Healthy Ideas being one of those. And Healthy Ideas. IDEAS is an acronym for Identifying Depression, Empowering Activities for Seniors. It is a no-cost, free. We keep telling people that because they think because it is a treatment, there is a cost associated. There is not. It is evidence-based, which means it's had measurable results and demonstrated benefits. So it's been tested, it works, and it is designed to detect and reduce the severity of depressive symptoms in older adults. There's 4 pillars. The initial is the screening for symptoms, and in our area there is a support coordinator in every county that we serve, and those ladies and gentlemen are the folks that would do the initial screening. If they screen positive, then the referral is then passed on to myself, and then I will pass it on to my program coordinator for follow-up. And included in that follow-up is initial contact. The client receives a lot of education about depression, what the options are for treatment, how to manage and maintain self-care. And this program can run anywhere from 4 to 6 to 8 months, just depending on the person, how much support they may need during that time frame. It is person-centered and individually planned out with that person's issues. They are taught symptom management by going over lists of activities that they might have enjoyed in the past. They choose an activity to work on and get back to that level that they were before all this started bringing them down. And then if at that point they still need additional assistance, like linkage to their primary care or mental health, behavioral health providers, or any other area resources, then we make that link for them as well. We will also role play with them in the home if they're not comfortable talking to their doctor about this. Michelle will run through a scenario of questions, how to broach the subject, and get the questions answered that they need. I do have some outcomes from previous folks that had graduated from the program. Older adults have reported fewer symptoms of depression, decreased physical pain, better ability to recognize and self-treat symptoms, and improved well-being through achievement of personal goals. So that is the outcome of what this program is supposed to do. And then a quote from one of our very first clients who we've already discharged, and she's moved on happily. And this quote came from her daughter. She said, "Mom doesn't want to miss any senior center days now," which I love to hear. "I bought her a QB bicycle machine, which she uses daily. She's cut down drastically on sugar and has lost 10 pounds in the last 6 weeks. I have to say that she is indeed doing much better physically and mentally. I can't help but think that our meetings with you, as well as the reading materials and education, helped her to turn a corner." So that's what we are pushing for. That is the outcome we want to see. So that is basically Healthy Ideas in a nutshell and what we are doing out in the community. If anyone has any questions, Michelle and I would be happy to answer them for you. Yes, ma'am.
Lucy, I just wondered if there are people here or they're working with older adults and they want to refer somebody to the program. What's the best way for people to do that?
The best way is to contact our RCS at 825-3100 and ask for their county support coordinator. Again, there is one for all 5 counties. They will then connect you to that person, and that is the person then that would do the screening.
There's a couple of flyers on each of the tables. And if you like, you can come to me afterward or lunch and I'll get your email and send you more information. But the phone number for RCS is on there. And you can call and ask for the coordinator in that county, and they'll transfer you there.
Yes, ma'am.
What's the time frame between the screening until somebody gets back to them? You had the education, the symptoms. So
It's
between the time they-
usually within 24 hours.
Oh, okay, that's cool.
Yes.
Awesome, thank you.
One thing that I wanted to share, and you kind of touched on it, but it really struck a nerve with me, was that I went to a presentation once, and the presenter said, you know, if our loved ones with cognitive and mental health issues had a wheelchair or a walker, it would be really easy, because everybody can visually see that they have a disability. But when we talk about mental health and cognitive disorders, it's, you know, it's so easy to sort of say to somebody, it's sort of like, well, why don't you just cheer up, you know, or, you know, buckle down.
Snap out of it.
Snap out of it. And I really, it meant a lot to me, because now whenever I think about that, I sort of reflect on, okay, there's no difference between this person and helping somebody with a wheelchair or walker opening a door. It's how can I help this person who might have a mental health disorder.
Absolutely.
And just to respond to that too, we wouldn't ever accept living with diabetes without treating it, or high blood pressure. And I think that that's sort of the pivot we need to make, is to recognize depression as a medical condition that doesn't have to be lived with, that we can address that and treat that and not just live with it.
That's the stigma we're trying to educate folks and get beyond, because that keeps a lot of people from seeking treatment. Yes, ma'am.
So can you help people that actually have dementia? Do you support that population, or is it just more like the caregivers?
I have a couple that I'm working with that have mild dementia. As she touched on, there's some sharing of symptoms, and it's a little more challenging for me because they'll select an activity. We'll sit down and go through as I meet with them, and I'm like, what would make their day more joyful? And I love to use that word. They really respond to that. They will think together and they'll come up with something. And then when I come to follow back with them, we write it down, and they'll take their folder home. And at the follow-up, they forgot. And so, you know, they'll forget an appointment. So it's a little more challenging, but I do, if it's mild, or they have a caregiver that's assisting, we can still meet them.
All right, or family member. And this is certainly open to caregivers as Loretta said, I mean, that can be a depression journey as well if you're an overworked, overloaded caregiver. So we certainly reach out to those folks as well. Yes, ma'am.
What did the acronym IDEAS stand for? Identify, Johnson?
Oh, you asked me too quick. Now I gotta look back. I can't ever remember it.
Depression Empowering Activities for Seniors.
Yes. Anything else?
Which counties again?
Culpeper, Madison, Orange, Fauquier, and Rappahannock.
When you mentioned the person had moved on, is there actually like a graduation thing? How long is
No,
it?
we just call
Oh,
it graduation.
But that's cool though, recognize that. That's really cool. You know, one of the things I share, I'm sort of adverse to a lot of meds, but obviously we know that in some cases. In my mother's case, one of the things I did not share was that my mother was, I did say my mother had some depression. She was depressed probably from the time I was born. I never met my father. My father left her for another man. And so that's always, just an interesting dynamic, especially back then when I was born. But one of the things I used over time, they had her on a really strong drug, I guess, when I was a preteen, but then the more I lived, like, we need to wean for some of this. So we just, I know it sounds so crazy, but we used the Lego, because she didn't do it for a while, but then when we got it back, we ended up doing that. And she really could express herself, even more so than on the drug. When I asked her how she was feeling about the diagnosis, you all had the minifigures. She popped the head off the minifigure and held it up and said, I fear, my greatest fear is that a few years from now, I'm going to lose my head. So again, she really could make that, and I put that on LinkedIn and it just got thousands of views. People really understood that. But I think I wasn't opposed to her taking it, but I didn't think she needed it then. It was great to like sort of wean her off. But that's why I asked about the graduation, how long did that kind of take? But she did well, I think.
And it depends on the person
It really does.
and the medication.
Yeah.
Unfortunately, some people take it, again, they don't see any results, so it's like, okay, well, this isn't going to work for me. I know my mother-in-law, after she lost her son and her husband back to back, and she was in that place. And we finally, got her to go speak with her physician, and that was back when Prozac was the happy drug, and they immediately put her on Prozac. And she was on it about a year, but I remember her saying, I need to come off this because I don't feel anything. I don't feel sad, I don't feel happy, this medicine just makes me numb. So in her case, that was not the appropriate medicine for her. There have probably been way better choices, and she would have recaptured some of that year had she followed up with a physician and been honest about that. But we had pushed her so much to go see somebody because she was so down. I think she was afraid to go back and say, okay, well, this isn't working for me, let's try something else. But, yes, sir.
Are there any restrictions with an individual who's already receiving either psychiatric care or with military, medical?
Nope, this is in addition to.
Okay.
That's great.
Anything else? Yes, ma'am.
I'm assuming that you guys are also working with them if they are on medication and if they feel it's not working, you're working with the caregiver as well, titrating them down, not just cold turkey with the depression meds. Is that something that you guys do in the program, is, making sure that whoever's coming in with them, the caregiver, is making sure that they're taking them and not just...
Right. I mean, we do educate about medications. We certainly defer to the ordering physician if it is something that they're expressing is not working for them. And we do underscore, you do not stop these medications cold turkey. It is a tapering down.
Yeah.
Anything else? Yes, ma'am.
Do you go to medications first rather than the healthy ideas?
It depends. If someone's already on medications, we incorporate that into our program. Typically, if someone is on nothing and they haven't spoken with their physician, and as Michelle is in there talking with folks, if they feel like they need to have something beyond healthy ideas, I mean, it's working a little bit, but maybe talk therapy or medication might be beneficial, then we would refer them back to their physician for any medication initiation.
I would say that's sort of part of the linking, is linking them with their primary care. Or psychiatrist, psychologist, whatever is most appropriate. It's very individualized, the program. Some people definitely would benefit from the medication, whereas others just would really benefit from talk therapy. Or maybe if they're socially isolated, just getting out. The senior center is a great program. If they're not already there, I refer them all the time to go to that senior center. There's a lot of engagement there, and they have, people of their same age and activity level, and they'll go shopping together. So it creates these social constructs that they can take outside of that that senior center and go shopping on weekends. So I'll refer them to there. Sometimes the referral is to a PCP or a psychiatrist to talk about medication.
Anything else? If not, thank you so much. And there are flyers on the table. Please feel free to self-refer or refer somebody that you may know, especially if you know of anybody who's been socially isolated, even more so during the pandemic, and you've noticed changes where they may not have, but it is challenging. But again, thank you so much.
And I've kind of